shortly. So welcome again to Hope on the Horizon, a community conversation about health equity hosted by the Brookline Community Foundation. My name is Giselle Farrow, Executive Director of BCF, and I will be the moderator today. I want to especially welcome our panelists, Rebecca Oni, Dr. Asaf Batan, and Dr. Swani Jet, all of whom I'll introduce very shortly. But I also wanted to share just a quick thank you to Brookline Interactive Group for broadcasting this on our community channel. You know, one of the hopes for our time together this morning is that we can all hear and learn more about what it will take to advance health equity from the perspectives of each of our three panelists. And I'd also love to share just a little bit about the Brookline Community Foundation. So I've been fortunate to join this organization last year. Our mission is to create opportunity and promote equity through the transformative power of giving. And we do this to advance vision of a better Brookline for all. BCF was founded in 1999 with a history dating back 100 years. We are the only foundation focused on supporting the needs of Brookline as a whole. And since 1999, we've distributed more than 10 million in grants and scholarships to the community. There's a lot of people who work collectively to help create a better Brookline for all of those who live, work, learn, and play here. This year alone, we've had more than 750 donors, 30 grantees, 19 trustees, and 6 staff members dedicating their time, resources, and certainly their efforts towards this shared vision. And I'm really excited this morning because we have an excellent panel. I want to share a little bit about each of our panelists. I'll start with Dr. Asaf Batan. He is the Executive Director of Ariadne Labs, a joint center for health systems innovation at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. He is a national and global expert on primary care policy, financing, and delivery, and serves as a senior advisor for primary care policy at the Center for Medicare and Medicaid Innovation. Asaf practices primary care at Brigham and Women's South Huntington Clinic. He is also a Brookline resident. Next up is Dr. Swani Jet. He's been the Director of Health and Human Services for Brookline since 2017. Formerly, he was a local health department leader in Seminole County, Florida, as well as Bullitt County, Kentucky. And recently, he was appointed to the Massachusetts Public Health Association Board of Directors. He's focused on improving communities and addressing issues involving the social determinants of health. And rounding out our panel is Rebecca Oni. Rebecca is the co-founder of the Health Initiative, a nationwide effort to spur a new conversation about, as well as investments in health. Oni previously founded Health Leads to enable physicians and other healthcare providers across the country to address the drivers of health, such as healthy food, safe housing. Among her many awards, she is a MacArthur Genius Awardee, a member of the National Academy of Medicine, and an Aspen Institute Health Innovators Fellow. She's given 2 TED Talks, one in 2012, another one in 2018, which collectively have garnered 3 million views. She's also a Brookline High School alumna and my former boss at Health Leads. Welcome, all 3 of you, and thank you for being here today. So I thought before we launch into questions, I wanted to take just a short moment to define health equity. In the simplest terms, health equity is the goal that every person is equally able to live a healthy life, regardless of their background or circumstance. This includes equitable access to health care, healthy food, a safe living environment, and the ability to be well across all aspects of life, from work to home life to medical care. Certainly, there's no question that the ongoing pandemic has had direct and indirect impacts on every aspect of each of our livelihoods. And yet COVID-19 is affecting Black, Indigenous, Latinx, and other people of color the most. Nationwide, Black people have died at almost 1.5 times the rate of white people. And Hispanic Latinos, at least here in the state of Massachusetts, comprise 12% of the population, but make up in Massachusetts 28% of COVID-19 cases and 17% of hospitalizations. So there's a clear disparity that we're seeing in this data. My first question to all of you is, equity requires eliminating those disparities, both in access and in opportunity across various systems. And each of you are leaders of systems with the power to create access and opportunity. What have you done to make equity-based changes? Essentially, how do we address this public health crisis facing communities of color and other vulnerable populations? Asaf, I'd love for you to kick us off, and then maybe Rebecca and Deswani.
Well, thanks so much, and really appreciate the opportunity to be here with you all and to be on the panel and to be in community with our Brookline community. A mentor of mine in medical school once told me something that really sat with me, and I think, to this day speaks to me. She said that to be a doctor, whether you acknowledge it or not, is a political act. And it's a political act because you sign up to treat every person not only equally, but you sign up to, if you really take on the mantle of community-based medicine, to really work on the determinants of health and to really expand access and opportunities in order to eliminate disparities. So, I look at my work as a practicing primary care physician, first and foremost, as a day-to-day journey alongside the patients and communities that I serve to promote equity. And sometimes that happens to be with a stethoscope or some medicine or an MRI. And a lot of times, as Rebecca can talk about in our work together and your work together in the past, and Dr. Jett can talk about his work at the county and city health level. So much of the journey is about getting people the services that they need, advocating for them, providing with them a voice to move past inequity. So first and foremost, I see my primary care work as really day-to-day equity promoting. And then the question on beyond a one-to-one or family-to-family level is, what can we do systemically? And, there is so much work to be done, and now is not a time to sort of sit back and say, oh, well, we did a few things. But, one of the reasons I went to work at Ariadne Labs and had the privilege to take over Ariadne in 2019 and really promote a sort of journey toward improved equity through designing, testing, and building solutions at scale that encompass that space between clinical medicine and public health, such that whether it's in our local communities around how to address the unconscionable differences and disparities in maternal mortality, the 4 to 5x fold increase maternal mortality difference that we see between Black and Latinx patients and white patients in and around childbirth, or whether we look at primary care and primary health care locally and globally, and see it for what it is, one of the main tools within a health system format for improving outcomes in an equitable, sustainable, and fiscally responsible way. I also look at some of our work in areas like serious illness communication, where we've made big strides in improving communication at the end of life, only to realize that in some cases, those strides have only increased disparities, where white patients of privilege, have more opportunity to have end-of-life conversations that orient them toward the kind of care journeys that they want end of life, but for very understandable, reasonable, and historically bound reasons. Black patients and other patients in minority communities can't or do not have the trust or are not given the opportunity and invitation to have those kinds of conversations. And so we're doing a lot of work around that, and a lot of work around taking conversations, not just in a medicalized space, but taking them to lay health workers, to faith-based leaders, and helping to promote the types of healthcare interactions and the articulation of purpose and goal setting for all people all the time in healthcare. So there's just a few examples that come to mind.
Thank you, Asaf. And I appreciate one of the things that you said, actually, that I never thought about, because a lot of the times we're looking at disparities in infant mortality, maternal morbidity, chronic illnesses, and I had never actually made the connection to that continues all the way to end of life. And so I just appreciate you raising that.
It's actually often even worse at the end of life, unfortunately.
Thank you. Rebecca?
Giselle, thank you so much for inviting me to be part of this conversation as a proud BHS alum. I really appreciate the opening frame around how do we make equity-based changes. That's the most pressing question upon us at this point in time. And, I think to be able to really address equity, we have to tackle issues of money and power. And one of the key questions is, where is the money? So if I could actually grab the first slide, there of course needs to be direct public investment in food and housing. But one of the things that's really important is to recognize that healthcare has the money right now. We're talking about health equity, not just because it's where enormous disparities exist and inequities, but also because it actually is where the money is. And you can see here that, we can talk about the Department of Education or USDA and SNAP benefits, food stamps benefits, but we have an incredible amount of money that is tied up in our healthcare system. And, we spend $11 billion a day on healthcare in our country right now. And how we choose to spend that next dollar is both a reflection of what we value, but also who we value. And so if we want to tackle equity, we actually have to take a very hard look at the healthcare system. So with my co-founder, Rocco Pula, our work at THI has really focused on how do you hold up the mirror to a system as vast and powerful as our healthcare system? Like, how do you even begin doing that? And just very briefly, one of the pieces of work that we've been doing over the past several years is working with a major national health insurance company. This is a $110 billion company. They have 40 million members and about 75,000 employees. And one of the first steps we actually took was to persuade this company to actually ask its own employees, are you struggling with feeding your family? Are you struggling with housing? Are you struggling with transportation? And it shouldn't be surprising, it wasn't to us, although it was to them, that about 25% of their own employees were struggling with those basic drivers of health. And, not surprisingly, there's 3 times as many Black employees in this company at lower wage bands than there are at higher wage bands. So this is like the perfect intersection, Asaf, as you were saying, between issues of race, drivers of health, health outcomes. And what was really powerful about these conversations was, I'll be honest, they started with like, we'll have a farmer's market in the courtyard, we'll have fresh fruits and vegetables in the workplace. And the journey that we've been on with them is really culminated actually this fall with they're creating a new health plan for their own associates that actually includes food, childcare, and transportation as part of the health plan. And I think that begins to be, how do we start to reimagine the purpose of our healthcare system through an equity lens? And candidly, that both can and should be the first step towards a much more fundamental reexamination of the wage structure, not just there, but in healthcare institutions across the country that we know disproportionately impacts people of color. Thank you.
Thanks, Rebecca. Dr. Jett?
Well, so, I will start. And first of all, good morning, everyone. My name is Dr. Swanee Jett. Of course, I've already had introduction. The 2 panelists before brought up some good connections. And, I would first start, by saying public health is a constant redefinition of the unacceptable in the human condition. And we need to create a sense of urgency about what is unacceptable. For decades now, we have measured the quality of life by health outcomes and the length of life. And what we should go back to, and we've placed like most of the blame on people's health behaviors. And what we should do is take a step back and look at the systems that create that. So the first would be looking at the policies, from where a person is living, air pollution, housing, etc., streets, parks, the safetiness of the community. Then the next factor would be moving to some of the social and economic factors, education, employment, income. And when I started looking at, well, how do I dive into this further in the community? And so first I have to inform the community what's going on. And it's a very hard pill to swallow when you start to dive into the health inequities that you see in the community. People don't want that mirror in their face. And what I mean by that is a community, once you start to unravel the policies that have created the situation, once you start to do a community health assessment and you identify that people in a certain community live better than another, the community is safer. And I take it one step further. At one point, I was looking at a community that people were suffering from cardiovascular disease and they had high cancer rates. And every day, people in the community were walking out to their cars and there was a black ash on the cars. Now, we didn't know exactly what it was. It was in a predominant African community. What we found out in investigating was that there was several plants in the community, namely rubber town. And those plants were emitting a toxic substance. Some of it was 1,3-butadiene, acrylonitrile, carbon tetrachloride. And these chemicals were attributing to cancer, respiratory disease, asthma, etc. Once we started to unravel the policy, we found out that people living in the community didn't have a voice. And Rubbertown, if anybody can Google, it's in the western Louisville, these were major corporations that bought this land for the cheap. And the community didn't have the ability to protest. And it led into environmental justice. The end game was that they made sure that the toxic release was monitored. 12 monitors was put into the city. Those companies were fined. They actually ended up being sued. The residents, there was a trust fund set up for $30 million. But it took the labor of the public health department, the university, and West Jefferson County Task Force to come together and create partnerships where we can investigate and do research. And it took quite a bit of money. Unfortunately, there was a lot of residents that did die over time from cancer. We couldn't find a study to be causative, but we could find that there was association from that plant and what we was noticing in the community. And only through the investigation and educating the community first, they started to protest because they knew something was going on. Were we able to find out what was actually a health equity moment?
Right. And, in each of your responses, you've mentioned that it's systems that have created and that result in these inequities. And so this next question is directed at Rebecca, but also certainly plays us off, and Dr. Jett, you can certainly weigh in as well. So organizations, so right now, and Dr. Jett, you mentioned the safety net and the importance of that. So organizations right now providing direct services, like food pantries, homeless shelters, are critically important for meeting individual needs right now. And Rebecca, I've heard you say in previous conversations that we've had that structural problems require structural solutions. Can you explain what you mean by that? And what can you and each of you share with people who watch this, hear this, are thinking about this, and want to move either their sector, their organization, or their work to create more equitable systems for everyone?
Yeah. No, I appreciate that, Giselle. I mean, one of the things that we think about a lot is this notion around, it's called systemic racism because it's in the system. And, when we see those, to your question, when we see those aerial shots of like thousands of cars in line trying to drive to the food pantry, like that's a system, right? And, that's not an accident. That's the output of a system. And so, I think just what I really appreciate your questions, like all of us actually work in a system. And the question is, how do we disrupt those systems towards the end of equity? And, I guess what I would say on that is, I think one of the most powerful starting points to do that is to actually really interrogate the questions that we ask. The questions we ask drive us to the presumptive answers. And I think a really powerful example of this is we've done work now for several years with the Secretary of Health and Human Services in North Carolina. And when Mandy Cohen became secretary there, she asked actually a kind of profound question. She said, what if I wanted to buy health, not just healthcare? And, it's actually kind of a startling question. She said, what if I wanted to use all of my financial and policy tools at my disposal towards that end of health? Like, what would that even entail? And part of what became so evident is like, we don't have at our fingertips good answers to these questions. And you could ask a question like that, to your point, Giselle, in any context in which you work, live, engage, any system could be asked that question. What's been fascinating about the journey since is really trying to say, okay, if every facet of the system were pointed towards the end of health, like how would we start to cumulatively get a different set of outcomes? And, so she did things like, you actually cannot be a health plan providing coverage to Medicaid patients in the state of North Carolina unless you agree to screen all of your members for food, housing, transportation, interpersonal violence. Like you're not even allowed to be eligible to be a health plan unless you do those things. She built a statewide resource database to say, okay, we actually need ways to be able to connect people to the resources they need in communities, but also, to Dr. Jett's point, really understand where are the assets and candidly, where are the gaps at a community level. One of the most interesting things she's done is been able to actually use healthcare dollars to pay for things like first month's rent or healthy food for folks, literally saying, okay, we are going to, instead of just spending our healthcare dollars on emergency room visits or hospitalizations, like we are going to literally take those dollars and spend those on the things we know people need to be healthy. The last thing I'll just say really briefly is, and I think this is one that we often miss, is, the question isn't just, how do we get people food? It's how do we think about getting people food in a context that actually addresses historical inequities and builds wealth in communities. At the end of the day, every analysis shows that like money is one of the most profound drivers of health, probably, second only, let's be honest, to racism as a driver of health. And one of the things that she and folks across the state have begun to do is to say, it's not just about buying healthy food for people. It's actually about sourcing healthy food from BIPOC food entrepreneurs, BIPOC food producers, BIPOC farmers, and really being able to drive, in this case, public dollars, although it could also be private healthcare dollars back into communities in ways that are enduring.
Thank you for that. I'll just react to that really quickly, and certainly then give Asaf and Sonia an opportunity to react if they would like to. But thinking about my own upbringing, my own background, I often and a lot of sort of my colleagues of color, friends of color, think about wealth building and generational wealth and the impact that has certainly, has had on me as a human, as an individual. Absolutely. Going through this life, right? And the impact that will have on my children, their children, and through the generations. And so, I'd love to hear that so many folks right now are not just talking about how do we build equitable systems, but how do we do that, just as you said, and also support wealth building for communities of color. So
well, I mean, Giselle, just to say one quick thing on this, because I mean, I think we often, we collectively often think about income or wealth, candidly through the lens of like individual responsibility, right? Like, are you saving? Do you have a bank account, right? But, the thing, I mean, part of the reason why I wanted to share that information at the beginning about like how much money there is in the healthcare system, like if that money is not meaningfully returned to communities, no amount of individual agency is going to somehow be able to match or mirror what it would mean for those dollars to be really deployed towards the ends of wealth and candidly, jobs and communities. You're totally right about that.
Right. Right. I have other questions certainly, but I want to give Dr. Jett and Dr. Baton an opportunity if they wanted to weigh in on that.
Yeah, so, the first thing I would say is, we talk in theory sometimes, and people want to see, or they ask the question, well, how do we actually, what's the data behind it to support it? Because, I could say there's structural racism, but when you look at a policy, they're like, well, we don't see it. And so I remember, and I use an example, because I remember when I was president for NACHO, National Association of County City Health Officials, one of the driving points was to ensure every health department became the chief health strategist in their community. And to do that, they had to do several things. They had to conduct several things. First, they had to do a community health assessment, which to me is the driving point of looking at health across the system. Then before any policy was developed, and any policy had to have a health equity lens. So if you're looking at, I remember one time somebody wanted to ban panhandling, it was ban panhandling, period, in a certain neighborhood. And I proposed the question, well, why would you want to ban panhandling? Why do you think that person is in your neighborhood asking for money? Most time you won't see somebody in a poor neighborhood ask for money on the corner. They was on the corner of a rich neighborhood. And a person thought about it. And I said, so you probably don't want to ban it. What actually occurred? And took them a step back. And they said, well, somebody aggressively knocked on my window. Well, so maybe you want to address aggressive panhandle. Oftentimes I have found when I began to unveil community health assessment, which is the first point, taking a step further, we looked at pedestrian deaths. And it happened, a lot of pedestrian deaths happen to occur in minority neighborhoods. So, I always tell my students that I teach, go do a deeper dive into a neighborhood. So as we begin to drive this particular neighborhood, we drove from the well-to-do astute neighborhood to the not so well. We noticed that there were sidewalks. Kids would get off the bus, their parents come pick them up, and they have been moved from the neighborhood. They left. As you got deeper to the minority neighborhoods, guess what happened? There was no sidewalks. Kids were walking in the street after school. So I approached one of the pastors in the neighborhood, and I approached one of the elected officials. And I said, I noticed that we have a lot of pedestrian accidents, but I also noticed that you had a lack of sidewalks. The parks were dilapidated. People were complaining when you start looking at no physical activity, people were obese, etc., and obesity rates were high. But I said, explain to me why there's no sidewalks in that neighborhood. And their response was, they didn't ask for them. To me, that's symbolic of the problem that we have, is when you build communities, you build one community better than the next. And it takes a systematic approach to look back at the racism that was involved, but also Just doing a community health assessment, you would begin to unravel what is occurring. We're taking one more step. We're looking at COVID these days. Now, most of the people contracted COVID in Chelsea, the housing was on top of one another. So people were packed. They were deemed essential workers, had to go to work. Okay, so they were exposed to COVID at higher rates than other people. I noticed this from in Brookline when I mandated a mask, that everybody had to wear masks. I first started with the essential services that were open because I noticed those workers in there were contracted COVID at high rates to anybody else. And it almost shut down places like Trader Joe's and CVS. So I really believe you have to take one step back and use data to support the initiative that we want to shift. Because otherwise it's an observational study and nobody wants to really look at me telling you what I've theorized, but they actually want to see numbers to support that.
Right. Thank you. Thank you, Dr. Jett. I have a next question for you, Asaf, but I also wanted to just take a moment to see if you wanted to weigh in.
I mean, really briefly, I would just to amplify what's been said, what Dr. Jett's comments made me think a lot about the fraying of a social compact that we have both locally and nationally. Nationally, we don't actually have a shared mental model, as the stories evidence, where we in this space here have a shared mental model about inequalities, drivers of inequalities, being able to connect the dots to structural, historical, social policies, legacies, et cetera. But that doesn't exist nationally. And that's evidenced by questions like, well, they didn't ask for sidewalks. So the lack of a shared compact and mental model around the root of the root, the why behind the why, is one issue. But I would take it a step deeper in our local community where let's say there's perhaps more, not complete, but more of a shared narrative and understanding, at least about the descriptors, the existence of inequalities, the existence of the legacy of racism and structural features in history borne out on health, on wealth, on housing. But here is where I think we have to have a continued conversation, and one that I think that the Brookline Community Foundation can really catalyze, which is it's not enough to describe it or to name it or to write an article or have a webinar and say, oh, well, that's too bad. Isn't that awful? Trust doesn't survive inauthenticity. And it's inauthentic as a community in Brookline to sort of say, oh, but we value equality and equity, and we that's just shameful. These inequalities are shameful. But then when push comes to shove with desegregating housing, making food more widely available, school issues, other community health issues, then we sometimes find ourselves in the, well, but that's a little step too far, or not in my backyard, or all that kind of stuff, which is a shorthand, quite frankly, for advertent or inadvertent continuation of racism and structural features that promote these inequalities. So trust doesn't survive in authenticity, and it's inauthentic of us as a community to say we are completely on board with equity, but then we don't kind of follow through with the next steps, because in order to promote equity, somebody has to give up something in order for others to have more equal chances at the things that we can all agree on.
Absolutely. And I just want to take a moment there too to pause, because I think, being new to the Brookline community in many ways, and certainly new to the Brookline Community Foundation, even in our mission, create opportunity, promote equity through the transformative power of giving. As a staff, as a board together, we're not just doing that performatively. What does that actually mean about what we do? Not just why we do it, but what we do to not inadvertently or advertently continue to promote those practices that lead to those inequities down the line. So I just, as the head of this foundation, I want to ask all of you and everyone, that is listening now or later to hold us accountable to doing that. So I appreciate you saying that, Asaf. So I do want to sort of move us along to the next question. And it was a little bit of a struggle because as I thought about the topic of this conversation and the timing of it, it struck me that we are a year into the pandemic, at least here in Massachusetts, when the first stay-at-home orders were done. And I thought, God, wouldn't it be great to talk about something more hopeful? And so hence the topic of this, which is hope on the horizon. And whether or not there is hope on the horizon, I want to believe that there is. And so, Asaf, I recall that back then, last March, you've certainly published various health-related articles that have gone viral over the course of the year, with the first one just a week into the pandemic. I remember reading that and being really struck by it. And so right now in Massachusetts and in many other places across the country, we're seeing the most recent wave dip significantly. And so what, from your perspective, what is on the horizon? How do you think about the conditions for broader scale reopening, and how would that impact the most vulnerable?
Well, yeah, I mean, it's amazing. It's a year, this coming week. I mean, I'm, in a short answer to your question, I'm cautiously optimistic. And not just because of last week's and this week's numbers, but, we are clearly on a path toward some form of herd immunity through a combination, unfortunately, of the numbers of people that have been infected plus vaccines. Now, we are in a race between the vaccines and the variants, and we have to win that race in order for us to not have a fourth major spike. And I think that we'll do that. I think that our efforts across Massachusetts and New England in particular to ramp up vaccinations are in whole moving in the right direction, but inequitably so. And that should be the crux of our conversation. In terms of reopening, we have to be able to have enough people vaccinated quickly enough in order for the more infectious and more harmful variants to not take hold, as they have not just in the UK and South Africa, but there are very concerning reports out of Brazil about variants in Brazil reinfecting people who formerly had COVID. So this is an area of concern. We're all watching it. The local health department is watching it. I think that the path to reopening has to be one in which we think, as we've been discussing, about not just COVID, but everything around COVID. So we need to maintain our stringent focus on all the mitigation strategies that have worked in this community, and not think that vaccinations plus nice weather equal, not doing the basics well, which will be with us through the fall and maybe even the early winter. I think the area where, for an equity focus, we need to spend more time and more focus and quite frankly, more rapidly make progress is seeing school reopening as a pathway toward health equity and toward societal equity. I think that, the preponderance of clear evidence from here and across the country is that schools should be, at least for K through 8, reopened 5 days a week. We can safely have kids in school, and we need to have a balanced view of risk about schools. So obviously we're trying to prevent transmission, but schools do so much good for kids in terms of nutrition, in terms of mental health, socialization. We've seen 25 to 30% increases in visits to the ER for both young kids and adolescents, since the pandemic. Social isolation is bad for social creatures like us humans. And so, I think that balancing this continued vigilance, focus on equitable vaccine allocation and distribution and with, you know, a proper and I think rapid focus toward really helping kids and their families get back into a routine, not this that's normal, but that's actually helpful economically, socially, nutritionally, and mentally for them.
Thank
Yeah,
you. And oh, thank you, Dr. Jett, please.
no, and I just comment. So, you know, we're moving toward a phase where people have COVID fatigue. And so, you know, my supposition is that we are probably closer to herd immunity because our numbers only reflect the people that are tested. And we didn't start like some other places did and ensure everybody got tested at once. So we didn't do the proper thing in terms of isolation and quarantine. Now we're moving to a phase where it becomes political, where everybody wants to open and to do it safely. And so as the Health Commissioner of Brookline, you know, when we start to move toward opening safely or changing the goalposts on infectious disease, then I say we have to apply the principles across every industry, whether it be schools. If we reduce the amount of distance, we need to do that for business and everything. What I have noticed is, and this is observational, but I do know that it's happening to not just kids. There's mental health issues now surfacing for adults. So if you start to look at your workforces, that they're faced with mental health conditions and their employees now are leaving their jobs or finding a job in employment. So in moving forward, we do, number one, we have episodic spikes in COVID cases. I think as a society, we have to decide what risk we want to take. And we have to have an understanding of that risk because along the way of reaching herd immunity, if we reopen at the rapid pace that I'm seeing, some people would die. And we have to have that unique understanding. And death rate has even though it's low in kids, there is still a death rate in kids. There's death rate, mortality rate along all spectrum, all ages. And so the community and communities abroad, this is probably the first time in American history that we're going to force reopening of various places and everybody not have a vaccine. And so that's the risk versus reward that we're trying to balance in today's world, which is different than any other time, any other pandemic or epidemic that we've ever had.
Right. So I heard in both of your responses say having a balanced view and an understanding of those risks. And, you know, so I wanted to just share also with the attendees, this will be my last question, and it'll be for all three of you. So, you know, I invite you to submit questions into the Q&A function. So from a mental health standpoint, which you've all brought in at various points throughout this conversation, the pandemic has created new barriers for people already suffering from mental illness. And I was reading a recent study from the National Center for Health Statistics found that 4 in 10 adults in the US have reported symptoms of anxiety or depressive disorder. And that's up from pre-pandemic numbers of 1 in 10. And, you know, I've also been sort of reading a lot about public health officials monitoring a growing crisis among young adults struggling with mental health problems. And as the pandemic wears on, so here's the question: how can communities help to mitigate those mental health issues that have just spiked dramatically?
So first, you know, I would say this, and I think a lot of people haven't really looked at the data. We had a mental health crisis in America before COVID. Mental health, you know, I always said you have to put the brain back in the body. Just like we have issues with oral health, you have to put the teeth back in the body, okay? We have not focused our resources toward mental health. Even in the school system, you know, what I noticed immediately is that we only have, I have 2 social workers deal with mental health in the school system. And the cases they have were spiking, increasing even before the pandemic. And I suggested to the school system, and I've seen this across the US, is that we need to increase the resources, not only in the high school, but at every level. Because the resources now to me was mainly focused at the high school level, one. Number two, Brookline Public Health, we provide funding to the Brookline Community Health Center, Mental Health Center. It's not enough resources. They are, their schedule is booked out almost for a month, which means more funding is needed. It's been like that for years. So this didn't just happen with COVID. Now, when you increase, people being isolated, which a lot of people are not, to me, I don't believe everybody's getting tested now when they get sick, because very obviously I see a lot of sick people walking around in the community. A lot of people are not getting tested now. Testing numbers have dropped dramatically. Okay, that's not a good indication if people are sick or not. But of course, if people not get tested, we'll never know. So people don't want to be isolated. They don't want to be quarantined, which makes public health measures more difficult than ever to control the disease. So, but we still have to focus in on what can we do safely to bring people out of isolation if they get sick, or out of quarantine to get sick, and move us to the new norm. And then the third level is just the funding piece. We have to be able, we talk in theory, we talk in what we see in observation, but every community has to do a deep dive into how far expanded is the mental health problem. Because when you know that, then we can be able to address the issue.
Thank you. And Asaf and Rebecca, before you dive in, I wanted to ask a follow-up question around this. It's related. It's a question from Mark, who asks, what equity problems do vulnerable populations and those with lower income face in seeking mental health care?
I mean, I'll just say one quick thing here, because I actually think that's exactly the right question. There's a bunch of pieces on the mental health front. Dr. Jett just laid out a number of those. I mean, there's the profound effects of social isolation. There's access to mental health care, which, as he said, has been candidly beyond abysmal long before this moment in time. I mean, I think the thing that's also important to layer on to that is just this recognition that, like physical health, mental health doesn't exist in a vacuum. And, being able to feed your family, being able to have confidence you're going to be able to make your next month's rent payment, knowing that you have a job. I mean, those have profound impacts on mental health. Just to Dr. Jett, your point on data, if it's possible to quickly just pull up slide 4 here, just really briefly, because I think it's useful to be able to take a look at this. There is a significant relationship. If we can do slide 4, Megan, that'd be great. There a significant relationship between right here, thank you, between food insecurity and mentally unhealthy days. This happens to look at it in Indiana, the state of Indiana. Those are all counties in Indiana. And I mean, you can just see like, it is like, it's a perfect line, right? The higher the rates of food insecurity, the higher the number of average mentally unhealthy days. If I can just get the next slide really quickly, this next one actually looks at the relationship that was just being asked around, income and mentally unhealthy days. You can actually see Norfolk County right there, at the higher end of the income spectrum. But this, you can just see dramatically the relationship between income and mental health. And so, I would just say, like any part of a mental health strategy, of course, has to go beyond clinical care, and just recognize that if we are not actually also addressing issues around, wages and access to healthy food, eviction, protection, et cetera, it's going to be very difficult to move the needle on the mental health issues. Thanks.
Yeah, so one of the things I would just highlight, because, I've seen this before and there's a lot of research on it. Talking about equity in mental health, when I became health commissioner in Brookline, infant mortality was at 9 overall. And everybody said, well, that's pretty good. It was at 9.0 per 1,000 rate. In the African American community, it was at 21 per thousand. So we had a lot of deaths from a clinical standpoint within 1 month. And when we began to dive into it and do a little more research, what we found is that in the African American community, women had dealt with a lot of racism and not a lot of support. So we had a Healthy Start program that one, I found out that they were not receiving clinical care until the third trimester. And so I developed an OBGYN program to engage women early. But also we noticed the social construct and the environment around them didn't lend the moral support that they needed. And then the mental aspect of dealing with racism every day and transportation system. When we did surveys and found this out, increased the stress on the body, which was creating inflammatory. So we began to hire more people into the program that actually came from the community and engaged the community. And after 2 or 3 years, the infant mortality in the African community dropped down to 10 per 1,000. And everybody that we engaged in the program, we had no deaths in the program. And so that's one mark to look at how mental health constructs actually impacted life. And so you're right, we have to begin to focus on the overall systems. School is one thing, but the environment in which people live has a critical play into the mental health. And so.
Yeah, just to amplify, I would say the majority of my clinical work this year in primary care has been in and around mental and behavioral health. It's just what we're seeing and doing every single day, even more than we were before. But as Dr. Jett said, it wasn't not a crisis before. Just you had to look. And now, like an X-ray, COVID shines a light on all the disparities and inequities that were already there, except it's brighter. For mental health specifically, their issues are really around access, both financially, insurance-wise, and also available providers. And I emphasize available providers. So even if we were to fix the sort of policy and payment mechanisms that allow critical mental and behavioral health services to be amongst the lowest reimbursed services in healthcare. But, so it's easier to get basically a fancy and questionably useful scan at one of our local fancy hospitals than it is to access concordant, helpful, affordable mental health therapeutical guidance. But even if we were to correct that, there's a deeper issue, which is there's a major workforce challenge. Now, the workforce challenge in Brookline is not as acute as it is in the majority of the country on one respect, in terms of number of therapists and mental health providers, psychiatrists, social workers, family therapists, et cetera. But it's as that theme we talked about earlier. You have to look underneath and look at the why behind the why. The issue is that many of our wonderful, and we are so privileged to have so many wonderful mental health professionals in Brookline, but many of them only take certain segments of private insurance or are self-pay or have full panels, or we go on and on and on. So even if we were to sort of equilibrate reimbursement and somehow make this all available, it's not available because, and this is one of the action steps we can take as a community, those mental health providers who believe in equity in action and not just theory can say that they are going to open up parts of their treatment panels to people who may not have the same insurance that they're used to get, or may not be able to do self-pay, or they may figure out that they should sign up to take Mass Health or other insurances that they previously had. That's a step toward equity that requires people to do something, maybe give up some privilege in order to get the outcomes that we see. In the interim, it's things like that, plus using integrated behavioral health strategies within and around pediatrics and primary care, where you basically use teams of providers working together to be able to see more people. But those are only stopgap measures.
Well, and this is a great sort of segue us off into a question from Pat, who writes, in my mind, supporting an improved Medicare for all system, also known as single payer, is the single most important way to achieve healthcare equity because it treats everyone equally under the law. Everyone is guaranteed coverage for all necessary care. There are no copays, deductibles, or other out-of-pocket costs that keep people from accessing the care they need. No tiered plans, and the whole system saves money and controls costs. What do you all think about that?
Well, I can start. I mean, to me, it's an unconscionable, inefficient, and kind of ridiculous notion that we still don't cover everybody in the U.S. So I agree with Pat about the fact that it would make much more sense on every level, ethical, disparity, policy, economic, to be able to have a single system of insurance coverage. There are a lot of different ways to get there, and the different ways to get there start to then confront the bottlenecks of our gridlocked political system. So, you know, I'm not sure that this is the best forum to sort of talk about how we get through that, but in principle, I mean, the evidence, and I've done a lot of global health work, both in high and low income countries, the evidence is overwhelming that countries that provide universal health coverage, or basically protection from catastrophic financial risk due to health expenditures, have healthier populations, spend less on healthcare, and get the outcomes that they wish to achieve. But we have a variety of past, current, and future roadblocks to achieving that in the US.
Yeah, I concur with Dr. Benton. You know, the key here is provide a basic level of health coverage, could be Medicare expanded for everybody. And then people that choose not to do that and have the money, they can buy additional healthcare coverage. Right? So, and what that would do, because this is done in other countries, would be, we know that you would get a standard level of care. But as is, in this country, we still have a lot of people that do not have health insurance. And, you know, when you don't have health insurance, you don't have the opportunity to go to preventive visits that you should. You don't get the proper screenings that you should. It costs the health system more money overall to not provide preventive care and to pay for it on the back end when somebody shows up in the hospital and needs surgery. Or they develop a chronic disease. And what I find in this country, we put less money in prevention. We put more money into end of life, which is a travesty. How about preventing a person from being in that situation in the first place?
So I have a question that was sent in for you, Rebecca, from Judith. Your early work focused on college students as your workforce. What role do you see college students playing in structural change? You're on mute. You're on mute.
Zoom. I was just saying that it's good to hear from you, Judith. I mean, I think, you know, it's interesting when we began our work really mobilizing college students around, you know, the work of connecting folks to the resources they need to be healthy. You know, that was the work of community health workers and promotoras and care managers and case managers was, you know, I mean, in some ways it had been present for a very long time, but hadn't been invested in the way that it has since then. And so I think there's a real opportunity to reimagine how we get young people as a force for action around these issues. I mean, I will say that I know that both Asaf and I began our journeys on these issues as college students together, actually. And, I think what's profound is, and, we just don't talk about this as much, but, when we think about like, what is the foundational understanding that we each need in order to be able to really move the needle on health inequities and racial inequities. There's an incredibly important piece around, what do we actually learn about, Dr. Jett, to your point about what drives health outcomes, right? And and I think that there is an enormous opportunity to really say, again, Asaf, to your point, we profoundly lack at this point in time a shared understanding of the ultimate drivers of health. And there is a real opportunity to say, if, college students and candidly, whether those are community college students, four-year college students, et cetera, if we are not serious about ensuring that a fundamental part of that education is around the most important drivers of health, economic inequality, racism, we will continue to get the systems that we have. I mean, I always think about how, systems, we talk about systems, structures, but at the end of the day, systems are just people making decisions. That is what systems are. It's people at all levels making decisions every day, and that produces a system. And so I think there's just a huge opportunity to be able to say, how do we really ensure that folks who will be constructing systems over time have a profoundly different education around what sits at the drivers of health.
Thank you. I do have a few other questions that have come in. Let me see. From Hannah for the panel. Brookline has a reputation as a well-resourced community, and yes, absolutely, sometimes the needs here are not well seen, but also the willingness to help is not being fully plumbed or deployed. How can we help share this new volunteer interest with other organizations and communities that may need these volunteers more than ours do? How can we share and develop Brookline residents' joys of giving for the benefit of others? Are there ways that you all have seen sort of volunteer engagement, community engagement across communities in this moment?
So, first, let me say this because, I think it's very critical that Brookline has volunteers and people that provide, whether it's resources or time and effort in Brookline. And here's the reason why. Every time I apply for a grant and I partner with different agencies, and not Brookline Community Foundation, but other foundations, the perceived notion is Brookline is well-to-do and there's no health inequities. And because of that, money is usually provided to communities that have a greater need. So, I'm reluctant to want to provide resources and volunteers to other communities because we actually need it in Brookline. Brookline does have a need. There are health inequities that exist in Brookline. There are social determinants of health that we have not addressed. And I would say this, in every emergency, whether it be natural, etc., the people that have the lowest resiliency to bounce back are usually less educated, minorities, and it's been exacerbated by the system. And if you look at any pandemic, look at Hurricane Katrina, this also affected, poor people that were white, but they were in rural parts and they were not addressed, issues were not addressed. And so we have to collectively, as a community, help build those resources within that community. And so I think that's where we need to focus, even in Brookline. We know where health inequities exist. Even though, we don't have a full enough landscape of the data, but we know from anecdotal observational data, what we see with our eyes, where we need to make a change and make it more equitable.
I really agree with those points. I used to work in a clinic for people who were homeless in San Francisco for 3 years when I was in medical school there. And I remember one of the patients I saw in continuity was a younger guy, and he, on top of all of his challenges, I remember having a conversation that stuck with me. And he said, I'm just so sad, and not just for the obvious reasons. And I asked him why, and he said, because here I am in downtown San Francisco, and this was the height of the dot-com boom, surrounded by all this wealth, by all this beautiful glassy buildings and people sipping their frappuccinos and everything else. And I'm sitting here, on the street, nearly starving, invisible in the midst of all this wealth and opulence. And I think that what Dr. Jett said was really important, that we are in an aggregate sense, and there are certainly pockets of incredible privilege and opportunity and wealth in Brookline. And in some ways, that can obscure and almost accentuate the inequalities that are not even seen or are perceived to not exist, whether it be in a grant application or in public perception or in the people available to help, because, it's just Brookline, they don't really need help. Let's go help people who really need help. It turns out being poor is being poor, and it's terrible to be poor wherever you're poor. And it might even, as my patient many years ago said, it might even be in its own ways harder or as hard or terrible to be poor in the midst of plenty. The other thing I would just say briefly from years and decades of work, both in primary care and public health, is whatever you do, whatever intention you have to volunteer to help, do it in longitudinality. Don't just show up. I mean, it's great to show up for one event or great to make a contribution. Those have their place, and it's very important. But the principle of accompaniment, of walking the journey, of if you say you're going to do it, then go every week or every month, not just for 3 months, but for 3 years. Walk with people on their journey. People in need don't want to be pitied. They don't want, help from wealthy people who can occasionally come for half an hour. They want to be seen as people in communities. The journey, the distance between them and you to be shortened. That's true journey walking and accompaniment. And I agree with Dr. Jett. There's plenty of that to be done locally, and there's plenty of it to be done within a 2 or 5 mile radius, and there's plenty of that to be done within a 500 mile radius.
And if I could just add one thing, because this is so important, to the comments that were just made. I mean, we actually did research here in Massachusetts with a bunch of a number of the major academic medical centers. And one of the crucial findings was that 25% of those with commercial insurance, meaning they had a job, still struggled with access to basic resources like food, housing, childcare, transportation. Like, we tend to think it's like, oh, it's those other people. It is not those other people. And I mean, I can say that from my own experience. It is not those other folks. And, we, I think, radically underestimate, especially in a place like Brookline, how folks are teetering, how they are just managing to have the pieces work. And any one of those goes awry. And in COVID, so much of that has gone haywire. There is, profound risk of folks, catapulting into very difficult economic situations, which of course then have profound impacts relative to health equity. And so that's just one piece. The other piece, just to echo a little bit of what Asaf was just saying, I think that that I would say that in addition to, the impulse to volunteer, that needs to be matched with an impulse to look within, right? And to really understand, okay, in the organization where you work, in the company where you work, what is the wage structure in the company? Is it an equitable wage structure? What are the benefits that are provided? How much are we asking our employees to bear the economic risk of bad health outcomes versus saying that that's something that we will actually hold ourselves, as we think about designing benefits? There are countless structural ways that are at our fingertips to be able to address these issues in sustained ways that will have a potentially much more profound impact on health and well-being in Brookline.
Yeah, I would just add, and just one last note, because Rebecca brought it up, and I was thinking it, and then she said it. I'm like, man, she must have read my mind or something. This is kind of scary. But I remember I was heavily engaged in the community, and one of the parts of doing a community health assessment is have focus groups, and I would show the movie Unnatural Causes is what's making us sick, and I was doing a deep dive because I saw such health disparities and health inequities in Seminole County, Florida. In Sanford, if people don't know, it's the home of Sanford, Florida, which is the second oldest African American community, Goldsboro, within that. And it's also the area when I became health commissioner, Trayvon Martin and George Zimmerman issue hit the spotlight. And so, here I am, the first African American health commissioner in Seminole County. And I'm wondering, why are people upset? And, some of it had to do with racism, but the other part was economics, right? And so I found myself, educated community, finding out the resources, working with the stakeholders, very granular level. And then I turned inward and I began to look at my payroll. And it was astonishing because I had, I'm running a medical practice as well as a public health department. It was more like a community health center because we did so many things. I had 8 docs on staff and I had a whole dental practice. And I looked down the payroll and I said, oh my God, I have health inequities within my own agency. I had staff only making $9 an hour. Imagine $9 an hour. And they were struggling week to week. Yeah, they had health insurance, but they couldn't pay the copay. And so, I looked within the state system and, 20 million people in the state, 67 health departments. And I said, is this the norm? Because I'm not familiar with this structure. And it was like, well, this is the norm. It's Florida.
Sure.
I said, okay. And I looked at my reserves and I inherited an agency that had $2.3 million deficit at the time. And I said, well, I turned the agency, did a quick turnkey and said, do I have the infrastructure to raise the wage level to at least $12 an hour? And after talking to my CFO, said, yep, I concur, we do it. Let's do it. Let's make that happen right away. And got a little flack from different levels. But when I made that change, it was a ripple effect because I wanted to encourage that change within my agency and then talk about that to other agencies in order to look internal. Because when you look at health inequity and things that we see, it starts within our own area, which relates back to Brookline. Before we look outward, we need to look inward.
You're not hearing me because I'm on mute, but I'm like, yes, yes. This is quite a few questions have come in, and I'm also watching the time, and so I think we have time for maybe 2 questions. This one question, I think it's for the panel from Robert. Dr. Baton said, we need to give up something to get something. What could realistically be shifted in the local budget to support unmet needs for underserved people? And now this is Giselle sort of doing a follow-up there, which is, how can local communities or states spend differently to support health for lower income or people of color?
I assume this is a Swanee Jet question.
I mean, it is, and also, certainly I know Asaf and Rebecca can weigh in about how to spend to get health.
Well, so one of the things I would just say, first, we have to know where to spend. I do believe there needs to be, it's going to be a long time for this to occur. I think on a local level, state level, and a national level, we need to look toward how do we improve systems. And if we identify, first of all, raising the income level for everybody is one step. Okay. Raising the level of housing. So to me, when you want to shift it, I want to build a healthy community. What do I want people to have? Number one, I want them to have, everybody have insurance. Two, I want to invest in the community. Every community looks different right now. It should look the same. Every park should look the same. If you live in public housing should look top notch. I remember in Louisville and in Chicago, they tore down the projects. And the reason I have such different lens on health equity is I grew up in Chicago. I grew up on the south side of Chicago. And I saw my community decimated due to economics and due to racism. When they began to tear down the projects in Louisville, Kentucky, and people might say Louisville, what I noticed is that they built townhomes. Those townhomes were state of the art. Okay. They removed the respiratory issues, the environmental issues that were in that neighborhood. They changed the parks. When I worked in Seminole County, we changed how the parks look. And so we have to invest in people. If you want to change the system, you have to invest in people. In Brookline, we have to invest in people and change the environments where people live to create better outcomes and better futures. And I would say there's a study out there. One of my friends, Rosen Harris, he took this place called Tangelo Park. And if you ever in Florida, it's Rosen Hotels. Everybody stay, go down to Disney World. What Rosen decided years ago, he said, look, all of my employees, there's a lot of minorities from different places. He decided to build health clinics within his hotels and offsite and provided everybody insurance that way. But not just for the employees, he provided for the families. Then anybody that lived in Tangelo Park, it was a very impoverished community. He said, if you enroll your kid in Head Start, they maintain a B average. Throughout high school, they would go to college for free. He would pay for it. And then you could come back and live in the community and reinvest in the community. Tangelo Park now looks state-of-the-art neighborhood because he invested in the people and they came back and invested in the community.
And I'll just say one quick thing here. To this thread here, we've been talking a lot recently about this notion of a healthy wage. We talk about it as a minimum wage, a living wage, but to really get at the heart of equity, we have to really think about what is a healthy wage. And let's be honest, it's not $12 an hour and it is not $15 an hour. Like those are, it's that may be better than the status quo, but that's candidly not good enough. And I think there's this really interesting piece about, we tend to think about the budget issues as like, okay, let's take money from X bucket and move it to Y bucket. And yes, there's some of that, but there's other things that are really powerful. As companies have started to really grapple with the issue of wages, part of the thing they've said is it's not just our own wage structure, but we actually will not work with contractors or vendors that don't actually pay a healthy wage. That is a profound way to think about using public resources and candidly private resources in ways that begin to really say, like, we recognize what these ultimate drivers of health are. We can fund, access to food and those things are important. But at the end of the day, if we could actually say, okay, Brookline has a goal of ensuring that everybody who both lives in Brookline and candidly who comes to work in Brookline is paid a healthy wage, that would have a profound impact on mental health, physical health, chronic disease, et cetera. And those tools are like right there at our disposal. Yes, they have economic implications, they have budgetary implications, but those are there for the taking.
I would just add one note too. You know, my observation, people forget we do have food pantries in Brookline, right? Food is expensive. Okay, so you know, one of the things I noticed, and I haven't seen this in Brookline, but I have seen, like, if you go to different grocery stores, depending on the neighborhood, the grocery stores look different and the quality of food is different. But if you want a healthy community, maybe the food need to be reduced so it's affordable. The food is very expensive. When you go in the grocery store and you buy produce, I think it's very difficult to accomplish that. And so you have to look at that food security as an issue that needs to be addressed as well. And funding needs to be put toward that. This pandemic, our food pantries have been overburdened, overwhelmed, not enough resources to help the community overall.
And I wanted to, I think so. I'll ask one final question before giving you each sort of the floor to offer any final thoughts to this conversation. And this question is from Rich. As we talk about health equity and the role of federal, state, and local money to address these issues, what are meaningful ways that communities like Brookline, and in particular, community members themselves, can be primary architects or designers of what health solutions might look like, rather than the recipients of those initiatives that are designed for them?
We're still thinking.
That as you think, you know, and I think it's what, if anything, have you seen across the country in other communities that we can consider as either a bright spot or even that's an attempt at community members helping to design the solutions that are meant to support them?
I mean, I'll say one quick thing on this. You know, one of the things that we've been working on, you know, elsewhere is how do communities get access to capital that they need in order to be able to, you know, build wealth, grow their businesses, hire local employees, et cetera. And, you know, one of the things that, you know, we've done is spent time, you know, really understanding from the perspective of community entrepreneurs, BIPOC entrepreneurs, like what are the barriers to access to capital? And candidly, what are some of the risks around taking on capital, right? Often access to capital is structured in ways that imposes debt, whether it intentionally or unintentionally imposes debt on communities of color. And you know, it's been really interesting, again, just to reference some of our work in North Carolina, is there's a set of, you know, BIPOC food producers that have, you know, have on the one hand heard all this talk about healthy meals and, you know, health plans want to pay for people to get access to healthy food, but have been really stymied, candidly, in being able to actually access capital from either health plans or from the State Department of Health and Human Services. And so, you know, it was with their kind of advice and counsel and their helping shape, we actually defined a set of investment principles that could then be brought back to institutions that have significant capital, and really begin to say, okay, we can bridge this in ways that honor and recognize the sort of unintentional risks that are associated with the deployment of funds by public and private entities into communities. And that kind of bottoms up understanding of what was needed, what is the type of capital that's needed, but also what's the ways in which that capital is structured, I think had a really profound impact around how we've begun to now create that bridge between the sort of public entities and the health plans and community entrepreneurs who need access to those resources.
Can you repeat the question for me again? I want to make sure I stay on track.
Yeah, absolutely. I'll repeat it. And then I think that it would be a great time also for each of you to just quickly and briefly share any final thoughts that you might have. So beginning with you, Dr. Jett. So the question is around how can we enable community members within communities to be able to be a part of designing the solutions that are meant to support them rather than just being the recipients of them. And then if you can just share any final thoughts with us as well as we close
Yeah,
out.
that's a good question because my mind wandered several ways. So, that community engagement part, that Office of Diversity Inclusion and the health department, and working with partners, we actually have to engage recipients of the programs that we provide. One of my goals is to do a community health assessment and build up the staff to do it, which will have focus groups in different pockets of Brookline to actually hear from citizens the needs. I was about to launch it when COVID happened, so it takes 6 months to a year to really do a community health assessment, and it's not only using data, but it actually is going focus in on neighborhood by neighborhood and really listening to the citizens and making sure we address the needs. We do a national community survey of the citizens, but it's done by mail.
Mhm.
But you really have to engage people and find out what are the needs of the community. I've done 2 community health assessments, and I've done it over a 2.1 million population. And then from that, when you develop a community health assessment, I'm usually working with hospital systems as well to help fund it. And then from that, let's say if we identify from the populace that diabetes is one, or lack of low wages or lack of parks, or whatever it might be, we list them 1 through 10, and then all of us put our resources together and we develop interventions to address it. And so,
Thank you.
yeah,
Sorry,
so
thank you,
good.
Dr. Jett. I was also going to say, I do recall from, I think, our first conversation that you were talking about developing a community health assessment. And, certainly as the Community Foundation, we would love to learn more and be supportive as much as possible. And I want to give the floor to Rebecca and Asaf to share some final thoughts as well.
I'll just say, very briefly, how much I appreciate this conversation. I don't believe this is one we were having, 20 plus years ago when I was growing up in Brookline. And just I'm appreciative of that, and really appreciative of, just how important it is to recognize that there is so much more economic diversity to Brookline than meets the eye, and the incredible opportunities that the town of Brookline has to be a real leader on these issues. But it will, I think, actually require some of what we talked about today, which is, to look in the mirror a bit, to ask some hard questions, to ask some different questions than might have been historically been asked. And I just appreciate the chance to be part of a conversation, beginning to try to frame some of those questions that can really take the town into the future.
Thank you, Rebecca. Asaf?
Really briefly, since our time is up, we in the United States have a really good system of rescue if you're really sick and you have a way to pay for it and you're privileged. We don't have a very good system for the rest of the things that build, sustain, and prevent you from getting sick. We spend $12,500 a year per person on that rescue system that's inequitable and clunky and great if you need an ICU and can pay for it, but we spend $56 a year per person on public health. I think if COVID doesn't teach us that that needs to be radically shifted and rebalanced, then we have way bigger problems. I think it will. I'm an optimistic person. I think also that change has to be a courageous act of radical reimagination. And that reimagination has to start with us seeing problems for what they are, seeing privilege for what it is, and starting to make meaningful, small and large, local and state and federal policy and personal choices. And even if that requires some trading and some discomfort, because we can't just name the problems, they're too pronounced for us to just sit by and let them drift along. I think we will do that. And I thank Brookline Community Foundation and fellow panelists for everything that you all are doing to push that forward.
Thank you.
Giselle, I responded to the question, but I didn't get a chance to do final thoughts. You mind real fast? Because I know we had time. You know, first I want to thank you for inviting me to be a panelist here, because I think we're at a critical time in the United States. You know, every pandemic, epidemic, or natural disaster, the citizens who needed the greatest amount of assistance are fragile. They were made vulnerable over time. And the burden of healthcare and public health, and all of us, is for these populations, disadvantaged populations in our society, to not just allow this to occur again, because there will be another epidemic or pandemic. There will be another natural disaster. So it lies within us to change this, not only as a community, but within our state and our nation. Thank you.
Thank you. Thank you, Dr. Jett. And thank you to all three of you and everyone who joined us for this conversation. It's our hope that you found it valuable, thought-provoking, and thank you again.